Muy buenos días a todos. Desde la Fundación Cardioinfantil queremos Néstor Sandoval y Tomás Chalela del Departamento de Cirugía Cardiovascular Pediátrica de la Fundación Cardioinfantil agradecer a todas las personas que se han unido, que tenemos participantes de Norteamérica, de Australia, de Sudamérica hasta Argentina.
Nosotros lo oímos, doctor.
Ok. En la presentación de hoy tenemos un invitado especial que nos va a hablar del estado del arte en la aplastia valvular aórtica. Como todos sabemos, la incidencia de enfermedad valvular aórtica y de enfermedades congénitas puede ser más o menos del 9%, y cuando se incluyen estas enfermedades valvular aórtica bicúspide, la incidencia puede subir hasta el 19%. En general es una enfermedad que cuando se vuelve de tratamiento quirúrgico es una enfermedad que generalmente se lleva de por días y por años. El tratamiento de la aplastia valvular aórtica ha evolucionado en las últimas 2 décadas y hoy tenemos a una de las personas más expertas en este tipo de tratamiento, y se trata del doctor Viktor Hraska, quien es no solamente un excelente cirujano, sino un gran cirujano, nacido en Checoslovaquia, estudió en Bratislava su medicina, posteriormente el Instituto de Enfermedades Cardiovasculares del Hospital del Niño en Bratislava, y después hizo su entrenamiento en el Hospital de Niños de Boston. Ha sido jefe de muchos servicios de cirugía cardiovascular pediátrica en Alemania, y actualmente el doctor Hraska es profesor y jefe de cirugía de la división de cardiopatías congénitas del Medical College of Wisconsin y director quirúrgico del Hernan Heart Institute en Wisconsin, los dos en Milwaukee. Como todos saben, el doctor Viktor Hraska tiene múltiples publicaciones, pero además de sus publicaciones tiene un libro que es un libro muy especial porque además acompaña y tiene una cantidad de videos de todas sus cirugías. De manera que agradecemos al doctor Hraska por acompañarnos el día de hoy, y Tomás va a hacer algunas recomendaciones antes de que el doctor Hraska inicie su presentación.
Buenos días, les recordamos que al conectarse a esta conferencia están autorizando el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 81 de 2012 y nuestra política de datos, la cual se puede consultar en www.cardioinfantil.org. De igual forma, les recordamos que esta conferencia está siendo grabada. Vamos a tener 4 preguntas abiertas y disponibles durante todo el procedimiento. Entonces, cualquier pregunta que tengan se puede hacer en el chat. Como dice el doctor Sandoval, es un honor y gusto para nosotros tener a Viktor Hraska en esta charla. Please, Dr. Hraska, you can go on with your presentation.
Oh, good morning. Good morning to Bogota. First of all, I have to express my enormous gratitude to Nestor for inviting me. For me, it's really a great honor and privilege to have this opportunity to talk about the aortic valve in front of you. Of course, it would be much more interesting to be with you, but situation now all over the world is somehow restricted in regards to traveling and so on. Secondly, what I have to mention is that Nestor is my old friend. We know each other for many years, and I always admire his leadership. He's not only a perfect surgeon, but he leads one of the best programs in Latin America in the world. So on the top of that, it's really a privilege for me to be with you guys. So I'm going to talk about the aortic valve, repair of the aortic valve in general. And I think it's fair to state that the management strategy in children with aortic valve problem is pretty complex. Because of this reason, as you see on the screen, one should take into consideration factors such as growth, active lifestyle, and difficulties in medical compliance. So these are the options, not many, but in general, the goal is not to compromise cardiac growth and kid lifestyle with the prosthetic material. In other words, to avoid aortic valve replacement, even at the expense of less than perfect repair. Of course, alternatively, in some children, the best option is still to use a mechanical prosthetic valve, despite the well-known drawbacks of these procedures. But one has to be clear that nearly in all cases, aortic valve surgery is a lifelong condition. It means it's pretty much palliation, and ongoing need for long-term follow-up is extremely important. So what I'm going to talk is to concentrate particularly on the technical aspect, on the surgical aspect of the treatment. So I'm not going to talk too much about the indication and long-term follow-up. Of course, I show you some data, but I will concentrate particularly how the surgeon should approach the aortic valve in different age groups and what kind of techniques are available. And I will be talking particularly about my personal experience. I'm doing this business for many years, so I will show you failures and the way maybe how we can improve the results. The repair has many advantages, as you can see. It's a safe, it provides the growth potential, no question about this. But in my mind, I think the most important part is that repair itself preserves all surgical options. And as I said at the beginning, it's very much palliation, so it's a temporary solution for a long-term problem. I think for the purpose of this presentation and from the methodological standpoint of view, I think it's important to divide repair to different categories, like simple, where no artificial material is used, and complex, where we have to use some material to replace the diseased part of the cusp or whole valve. So I will start with neonates because this is a very good example of simple so-called open valvuloplasty technique where any artificial material is used. So what is available for neonates with critical aortic stenosis? Yes, we have two options, surgery and ballooning, and both are simple and safe. But I think this is important to recognize that whatever we do, either with balloon or knife, it's a palliation, as I said. However, the long-term preservation of the native aortic valve seems to be dependent on the morphology of aortic cusp and the method used. And I think this is the point which I like to make, and you will see shortly what I'm talking about. The balloon is a very simple method. So if you are talking with cardiologists, they said, well, what did you do? Well, I just inflated the balloon and so on. But one has to understand the mechanism of this balloon. Balloon, by definition, is a very or strictly symmetric method, which is used in a strictly asymmetric environment because the valve of critical aortic stenosis is everything but not symmetric structure. So when the forces are distributed, and they are distributed evenly, of course, the valve is torn at the area of least resistance. So never ever, and I will show you a video shortly, never ever the valve is open in the commissure. So that's why we see the pictures like this. The result with ballooning, despite this technical drawback, methodological drawback, the results are really very good. But when you look on the all published papers, unfortunately, we are mixing apples with oranges, and we are evaluating neonates together with infants and the older kids. So it's difficult to interpret all this data, but I put together some data here published during the last 10 years, analyzing more than 2,500 patients. But as you see, the mean age of all this presentation was nearly 3 years. So we are not talking only about the neonates, but we are talking about the broad spectrum of the patient. Survivor is very good, is 90%, and reintervention free survivor is about 50% across the board. So it's pretty low at 10 years of follow-up. This is very important paper which was published several years ago, and this is the first multicentric study where they prospectively try to evaluate the effectiveness of ballooning. So yes, they did the multicentric protocol and analyzing more than 373 patients in prospective way, and the goal was to evaluate the acute procedural success. So we are not talking about the long-term outcome, even discharge outcome. We are talking about the outcome immediately after ballooning. And for the purpose of that study, they defined the success as a residual peak gradient less than 35 millimeter of mercury and no more than mild aortic regurgitation. And these are the data for neonates. Of course, it's a busy slide, but just to concentrate on this column, which represents inadequate results, which were achieved in 1/3 of the patient. And definition was gradient more than 35 and more than a mild aortic regurgitation. So you see that the method has some effect, but it's not 100%, of course. On the top of that, there were 53 adverse events in 47 patients, and age less than 1 month neonates was the only factor independently associated with increased risk of high severity adverse event. So in other words, if we conclude this paper, which is very important because it's prospective and multicentric, done on the current state-of-the-art environment, they found that inadequate procedure outcome was achieved in 1/3 of newborns, and the procedure-related morbidity was noticed in 20% of patients, demonstrating that the less invasive approach is not necessarily the safest. Surgery can be much more predictable, and this is the essential advantage. We are not doing only commissurotomy, but we are resecting myxomatous tissue around the valve, and that makes a big difference. And particularly what we are doing is everything is done under direct vision, so one can shape the type of surgery according to the morphological anatomical needs. Again, I put together some papers, not too many actually, in this segment, close to 600 patients, mean age, the same problem. We are mixing apples with oranges. Survivor, 94%, just remind you, balloon is comparable. Talking about the survivor in neonates, it's not about the technique. It basically doesn't matter whether you use a balloon or knife. It's about the indication. It's about our better understanding of limits of biventricular repair, because if you look to all the data, usually patients who diseased were from the category suitable for one ventricle palliation. So I think we made a significant progress in our understanding of suitability of the left part of the circulation for biventricular repair, and that reflects the survivor rate. Reintervention-free survivor in surgery is 74. Just remind you, it's about 54 in balloon. And this is a very consistent finding. Whatever you open, whatever type of presentation, you will find probably this type of data. However, it's very difficult to find just the data about the neonates. We concentrated on that because we had a lot of experience in my previous place in Germany. So we put together our 26 years single central experience, and it was published just recently. And these are all patients. who were operated from 89 to 2016. The blue columns represent surgery, the red balloon, and as you see, that's basically how one would expect. It was a work in progress. With time, more balloons were done, then more surgery. But what is consistent is that with gaining experience, we more or less prefer the surgery, let's say from 97, 98, and the surgery completely prevailed during the last more or less decades. We analyzed 103 patients, and these are the results. It's funny that these patients were nearly equally distributed, 52 to 51. And as you see, there's no difference in survivor, just confirming what I elaborated in the previous slides, that survivor reflects indication, not the technique which is used for these babies. Freedom from surgery is significantly better for open valvuloplasty in comparison balloon. And I'm talking about the surgery because there was always an argument from the cardiology side that we are talking about the reintervention, and the balloon itself is designed to provide 2 or 3 ballooning to achieve the optimal results in the long run. So we should not calculate that because that's the part of the protocol. So we accepted that. So we look only on freedom from operation, not freedom from reintervention, which of course handicap evaluation of ballooning. But nevertheless, the result is statistically significant. But this is the most important message from our experience, that if you are able to create a tricuspid scenario with your surgery, the freedom from aortic valve replacement is really significant. It's about 90% at 10 years of follow-up, and it's significantly better, statistically better in comparison with the bicuspid scenario. So that leads to the question, which patients are better served with open valvuloplasty versus ballooning? Well, I think one has to take into consideration morphological stuff. So it's very true that all type of valves can be handled by surgery. Yeah, there is no limit because you see what you have to do and you open the valve according to anatomy. You are not splitting the valve if there is no support and so on. For ballooning, based on what I previously said, that it's strictly symmetric method, which is using strictly asymmetric environment in majority of cases, the best results I achieve in a relatively symmetric environment like bicuspid or true bicuspid valves. So now let's get through this morphological aspect. So this is and I hope that this video is working. If not, please let me know. I'm not able to now to control that, but please let me know. So what we see is a cross-section area of a unicuspid valve in neonates. And this is the picture from the operation where I split this commissure because after the splitting, there was a support of the free edges, free margin. Despite the fact that commissure is underdeveloped, as you see right now, this is the origin of right coronary artery. So the commissure is significantly under, so the valve is more or less flat in this area. But nevertheless, if you look on the commissure properly, and if you find the potential support, one can split it, as you see right here. And this is the result after surgery. There's a minimal regurg, and the gradient measured with very good function, by the way, of the ventricular discharge was 24. This is something which we see nearly in every bicuspid aortic valve, that you will end up with a gradient between 20 to 30. Bicuspid valves, as I said, bicuspid valve is probably a very good target for ballooning. And this is the paper who showed that the freedom from repeat intervention, death, or transplant is significantly better if valve is functional bicuspid before and after than the other so-called valve morphologies. But what we see most frequently is this scenario. We call it garden variety of the valve, which is basically functionally bicuspid or unicuspid valve. However, this valve usually can be converted to the tricuspid, and I show you that. Again, the video, you see is a neonate. You see the very thickened, flat valve. On the other hand, the annulus, it's about 8 millimeter, which is perfectly okay. And now in cross-section, one can see the commissural post, and most likely this valve will have 3 commissural posts. And this is the valve which you saw on the echo during the operation. And you see the description. This is a fused commissure between the left coronary and right coronary. And now you will see the fused commissure between the right and non-coronary. Commissural posts are actually not so well developed, but as you see, they are supporting the free edges of the valve here. And you have to split it in a proper way to preserve this support. If you do that in that way, you can achieve a reasonable results. But the most important part, of course, splitting is extremely important because you are changing the geometry. But to achieve a really good, effective orifice area, one has to do a shaving of the valve, and usually very aggressively. Well, it very much depends on the amount of the myxoid tissue, but many valves are very premature, and sometimes it's challenging to grasp this tissue and to do a ballooning. But as you see, one can achieve a tricuspid valve scenario with a nice opening, and this is the result of that. It's a mild regurg, and no obstruction, no stenosis, and tricuspid scenario. And this mild regurg usually doesn't progress or even disappear during the remodeling of the valve with time, because the valve is still very immature. So what we have learned in neonates, we learned that valve morphology determined the need for intervention and replacement. And we know now that restoring a tricuspid anatomy clearly yields superior long-term result for preservation of native aortic valve. And so this is the main indication for surgery. I think that if you see on the echo that you can create a tricuspid scenario, I think one should go for it, because in the long run, it can offer really very good functional outcomes for patient. You know, to have a 90% freedom from aortic valve replacement, it's extremely important for kids. So if you can, during the counseling, if you speak with parents and say, well, yeah, this neonate, your baby has a very progressive stenosis. However, we can restore tricuspid anatomy, which most likely will work for many years. That's great. So now let's talk about the children and young adults repair. Of course, one can use valvuloplasty alone, but it's usually unlikely, or there's not too many patients for this type of reconstruction. But the principles are exactly the same. Usually, we are challenged by the complex situation where the complex reconstruction with artificial material must be exercised. I'm not going to details of anatomy. I think everybody knows that. But what I want to highlight is so-called effective height. And you see that on the screen. The effective height is the difference between the center-free margin and the aortic insertion line. In kids, it's somewhere between 4 to 9 millimeters. We don't have tables which are corrected or recommendation which are corrected for BSA. In fact, we are working on that in my institution, which will be very helpful during the reconstruction. But The numbers for adults are very well established. It should be somewhere between 7 to 12 millimeter. How to measure that? Well, there are two different calipers. To use it, I prefer the caliper on the left side of the screen, but you can use the different instruments for that. But I think it's important to have some kind of reproducible metrics, which is helpful when you are uncertain whether the reconstruction is okay. Another very important concept, and basically I was talking about this in neonates, is opening of or creating of tricuspid valve. So when you look just from the geometrical standpoint of view, if you have a tricuspid scenario, your circumference is equal 6 times of diameter of radius. If you have the same aortic root, it's just 4 times of radius. So the difference is significant. So whenever you can achieve a tricuspid scenario, I think it's important for the long-term outcome because you will achieve better functional outcome immediately after surgery. Patch material is a headache. We use whatever was available in the market. Every 5 years, some new vendor comes with new material. However, all these materials are failing, and that's an essential problem of the reconstruction. So first, I will show you pericardial patch cusp extensions technique, which is basically simple and highly reproducible because you remove the diseased part of the valve and you extend this diseased part of the valve with these pericardial strips, and you can nicely create a high effective height and so on. The potential trap is that if you are trying to create a too high cusp, you can affect the coronary perfusion, which was published in several papers. So that's how it's done. On the left part of the screen, you see the first, we should start with the commissurotomy and shaving. Then the valve is extended with the strips. These strips has to be redundant. This is very important, has to have this type of shape. And then, as you see on the right part of the screen, one can achieve a good result, despite the fact that if you're looking on the echo, you see that the valve is not completely symmetric and one leaflet is smaller than the other because you are basically trapped with the morphology which is there. So you have to just replicate this morphology. You cannot transfer the commissural post and create more symmetric valve. So that's another disadvantage of this technique. Another technique which I personally prefer is tricuspidization of unicuspid or bicuspid aortic valves. And the technique is, I think, very simple. You see the example of bicuspid valve where the right and non-coronary cusp are fused. So that's our target because usually the freestanding leaflet, in this case left coronary cusp, works as a benchmark in majority of cases. So what one has to do is to detach the right coronary cusp from the hinge point, then to twist the valve and to create a non-coronary cusp from the native valve. So you will end up with 2 native valves, and the gap is filled with the patch. The patch should have a specific shape. I think this is important to recognize. It should be of this shape, and the width should be plus 20% of the diameter of aorta in order to compensate for dynamic distension of ST junction during the diastole. And the height is governed by extent of augmentation and anticipated height of newly created commissural post, and can be measured with these calipers which I show you. I will demonstrate this technique on and I think this is a very typical example. It's a 14 years old, no interventions, came with the severe aortic regurgitation. So it's a really very good target, because if you have a severe aortic regurgitation, usually you have a nice aortic root, so you have enough room to work with. So again, I hope that video is working. So what you see is right coronary artery and the fused right and left coronary cusp. You see the complete fusion. And the posterior commissure is always normal and can work as a reference point. So you should put a marking stitches for the other commissure based on the posterior commissure. Now one can appreciate the coaptation deficit, and the surgery, as I said, consists of detaching of diseased part of the valve. In this case, it's the right coronary cusp. And the new left coronary cusp is created by creating a new commissural post for the left coronary cusp. So the tissue which was detached is simply used for this cusp. Sometimes it's necessary to shave this tissue, of course, to improve the mobility. And now when we created a situation with two native leaflets, the right coronary cusp is created from the pericardium of the shape which I presented. What is important on this technique is this part, when you are transitioning from the base to the commissural post. So one has to take really pretty short bites on the commissural post and relatively large bites on the valve itself, on the patch, in order to create this typical geometric appearance, this so-called bra type of appearance, which increase the coaptation and will provide the appropriate effective height for this leaflet. Of course, the patch is redundant, but then you cut it off and you create a shape which is appropriate. And now you see how the valve was created, and this is a echo at discharge of the patient. So nice symmetric valve. I think that's important. You see, of course, the valve is the leaflet which was replaced is thicker, but there was no regurgitation and stenosis. So we are able, and the technique is not so difficult, and it's reproducible. We are able to achieve really very good results, reproducible results at discharge. Sometimes you are, of course, having a problem in OR, whether your result is okay, or you should just go back and try to reconstruct it again, or to do a ROS or something else. We believe that the accepted result in OR, of course, anticipating that left ventricle function is okay, is a peak gradient less than 30 and aortic regurg equal or less than a mild. So what are the advantages of this technique? I think the advantage is that you are replacing just one valve, one leaflet, and you are preserving two native in anticipation that they will grow and potentially will compensate the shrinkage of replaced valve. Well, this is in theory. Of course, this technique is failing as well, but I believe it's the simplest and most reproducible way how to reconstruct the valve in youngsters. This example of reoperation, as I said, it's failing. So what you see is reoperation, I think 3 or 4 years after the primary surgery, where I replaced partially this valve, partially this leaflet. It's a non-coronary cusp. However, preserving bicuspid scenario, and you will see shortly why is that. So we ended up with relatively okay result, but the valve simply failed. And you see that I didn't split this commissure between the right and the left. And now I'm splitting that, and that's the reason why I embark on a repair that I said, well, let's change the geometry to tricuspid and having a better functional outcome. So the reason why I didn't split it at the first time was, as I demonstrated, that there was a fenestration in the commissure, and the first time I was afraid that I will not have appropriate support. But now When the patient was older, I was able to split it. And then we did the regular replacement or replacement of the patch of the leaf of the cusp with additional patch. This material which you see is a cardiocell, which we use at that time. And this is the end result basically. What you have to do, I didn't mention that it's good before you cut the leaflet to appropriate shape to put a stitch to the nodulopharynx to have a clear understanding of the radius on the both sides of replaced valve. So now I'm measuring the effective height to be sure that the valve which was replaced is appropriately shaped. And the result of that was pretty good because, you know, you have to create a really redundant situation. You see the redundancy now. What about youngsters or teenagers and young adults? Well, now the replacement of all leaflets is pretty fashionable, but we started with this technique many years ago, actually. I show you the example of one of the patient, interesting one. He was a goalie in our soccer team and football team, and he came to me and said, well, I need a reconstruction of the valve. And what I did at that time, you see the situation 4 years later after primary surgery. I replaced or reconstructed his valve with pericardial strips. So all 3 leaflets were replaced. And now you see the consequences. You can appreciate the border between the patch and native tissue. And all these pericardial strips calcify heavily. So when he came back at 4 years, he had a combined severe aortic regurgitation and stenosis. And of course, nobody is surprised with this if you see the valve of this quality. So this material calcified very quickly. So I ended up with this situation, but he insisted on re-repair because of his engagement to the sport. So I decided to replace all leaflets, and the technique is exactly like I show you with one leaflet. You start with one leaflet, which in this case was right coronary, and you created like a benchmark leaflet, a benchmark cusp. Then you develop the other one, which was left, and now I'm trying to fit the non-coronary cusp to this scenario. As you can see, I put the stitches to, or leading stitch to nodulopharynx to have a understanding of the radius. We measured the effective height and so on. And that's the situation of the reconstruction. And this is the echo discharged, pretty symmetric valve, no regurgitation or minimal regurgitation and no stenosis. And this is exactly the Ozaki procedure, but Ozaki, you know, I'm eyeballing surgeon. I'm measuring something, but I'm eyeballing surgeon. And of course, Mr. Ozaki is not, he's Japanese, so they are measuring everything. So he came up with a very reproducible, sophisticated way how to measure the shape and how to create appropriate shape of a leaflet or cusp, which I use for complete repair of the aortic valve. And you see the principles. The principles are very similar to what I show you, but it's measured. It's you have a confidence that if you measure it correctly, you will achieve a really very good result. So you are not so much dependent on eyeballing, on evaluation of the actual situation. It's more reproducible, and he achieved fantastic results. It's incredible. When I read this paper was published many years ago, as you see, but you know, this is striking. The freedom from reoperation at 10 years, about the 90% in more than 400 patients. But we are talking about the adults. We are talking about the roots, which are really large, where you can oversize the leaflet, because that's the essential key of this technique, oversizing the leaflets, and then you achieve a pretty high effective height, and that determines your coaptation. And that's why the longevity in this age group in adults can be provided, because the root is not growing anymore, and the calcification process and all this attrition is much slower in comparison with our kids. So where we are in using this technique in our young patient. This is a paper which was published just recently, last year, coming from GOS from London. And the senior author is Martin Kostolny, who is one of my trainees, and I'm very proud of him. And they put together 58 patients, and they compared two techniques, Ozaki, as you see in nearly 70% of patients, and single leaflet reconstruction. They haven't had two young patients. The youngest was 10 years old, which is relatively old. So they concentrated on the group of patients where Ozaki can be done, and you will not end up with very crowded aortic root, because that's what can happen if you use this technique in small patients. This is the freedom from redo at basically 4 years, which is 70 or 3.5, nearly 3.5 years, 70%. Well, yes, one can say that it's okay, it's reasonable. You postpone for example, Ross, or you buy a time and so on, but definitely it's not the results comparable with Ozaki. So if you look on comparison between the Ozaki and the single leaflet replacement, Ozaki is red, the result is exactly the same. So from the technical standpoint of view, one can say, well, there is no difference between these two techniques, so probably it's not about the technique. So if you look to the material, because they use two different material, autologous pericardium and bovine cardiocell tissue, again, no difference. However, autologous pericardium probably will outperform with time. At least the tendency is a positive, but again, statistically, no difference. So these are the conclusion that aortic leaflet reconstruction provides acceptable short-term hemodynamic outcomes and proves the utility of this technique. I'm talking about Ozaki, as an injective strategy for surgical treatment of aortic valve disease in children and young adults. But what is important to recognize, and this is not a trivial, is the higher incidence of infection endocarditis. It was 5%, which is pretty high, taking into consideration the fact that the follow-up was a little bit more than 3 years. And now we have one publication. I have to mention that because Thomas was involved, and he is a great guy, and I very enjoy working with him. He spent with us nearly a year, I guess, and it was very nice. So we put together this case report because it's interesting, and it's according to the lines what to do with the endocarditis in the youngsters. So I will present this case report, a very typical scenario, I would say. Patient born having a congenital aortic stenosis, however not severe, needed balloon at 8 years. First operation was at the 16 years of age, and you will see that. That's what we did at that time. You see the aorta, the head is down. That's the orientation of the picture. Tricuspid, a little bit asymmetric valve, very thick and fused. So I did a commissurotomy shaving, and I did this pericardial extensions. At that time, I was very enthusiastic about this. And we downsized the annulus, and we replaced the ascending aorta to stabilize everything. It worked very well, actually. However, she came back at the age of 19 years, so 3.5 years after, with endocarditis and septic embolization to the brain and so on. So we had to do something. So this is the echo before. You see the thickened valve, mobility is limited, minimal regurg still, a little bit of stenosis. So that's the orientation of the video: left coronary, non-coronary, and right coronary cusp. And hopefully video will move, and hopefully it's moving. And now you see an enormous amount of endocarditis masses, which invaded the surface, the surface of all three leaflets. So first, I wanted to understand how these leaflets are destroyed. So this is the first hole which we found in the non-coronary cusp. So I cut off this non-coronary cusp, and I found the abscess here sitting on the right coronary cusp. I was pretty uneasy with this because, you know, the conduction is pretty close. Yeah, the conduction system is probably there. And you have to open the abscess to just be sure that you are not missing anything and the whole cavity is explored. So I was working on that. So you end up with this hole there. So one has to close it. So we use a couple of really heavy sutures with the plagets just to close it. But we were lucky because the margin of this abscess was pretty solid, so it was not so big deal. Then we recognized that the mitral valve is affected, so there was a hole on the anterior leaflet of the mitral valve. Again, it was nearly healed because you see the edges were pretty good. So I closed it directly, and the rest of the mitral was fine. And I realized that two remaining cusps, which I reconstructed 3 years ago, are working fine. It's so I decided to just replace this non-coronary cusp and to give a chance for the healing and for curing the infection. Of course, we had to measure the annulus. That's always what we do, and effective height and so on. And so now you can appreciate the final result. You see the replaced cusp, you see the closed mitral valve, and the abscess was closed as well. So redundant, tissue must be redundant, this cusp must be redundant, so that's what we achieved. And mobility was pretty good. I reinforced the commissural pose to be sure that it's holding nicely. And that was the result, which was very encouraging. Mobility of these two remaining leaflets were not perfect, but perfectly okay, not to create any significant gradient, and there was this trivial aortic regurgitation. Why I'm showing you that? The reason is that afterwards I did several of these patients. I have to take a look and analyze that, but because recently, about 2 years ago, I did one, and exactly like this, and he was back after 2 years because the valve failed and he wanted to ROS. But this is, I think, the main message in regards to the reconstruction of valve which is affected with bacterial endocarditis. Without short-term recovery, there is no long-term outcome after surgery for endocarditis. So you have to just solve the situation and buy a time, and then you have all possibility how to deal with this, instead of jumping directly to, let's say, ROS or allograft or mechanical valve. So why these valves are failing, which is of course frustrating, because you spend a lot of time to do it, and then a patient is back 3 years later, and it's always a difficult discussion with him and parents and so on. So you see one example, no regurg. However, the leaflet which was replaced, and you see which one because it's thickened, is not moving basically, and the remaining cusp are not able to compensate. So this is exactly the same patient in 3D arrangement, and you see better this is part of the leaflet. But the best, but still, if you're looking on this, say, well, maybe it's going to work, but it doesn't, because the leaflet is completely stuck at the hinge point. So the hinge point is a problem here. The free edge is opening a little bit, but the hinge point of the leaflet is creating the enormous turbulence which destroyed the remaining two cusps. So that's the mechanism, and that, of course, this acceleration of the flow facilitate the calcification and fibrotic changes, and that, of course, leads to the lack of elasticity, growth, and stretching and tear. On the right side of the slide, you see the cardiocell, actually. You know, I was very optimistic about this material because the essential advantage supposed to be zero calcification, and this is not only one paper which showed that. This is a native tissue here, basically in this area, and the patch starts here, and you see the calcification, fibrin, and all this stuff. So, for example, this is a picture of the patient which I show you actually with the echo. The leaflet is simply stiff. It's completely destroyed here, going completely down and cannot move, and that's why you end up with acceleration of more or less deterioration on the native cusp here. So one can still replace this cusp and open it up, but it depends on basically parents or patient wish. Now, shortly I get through all the data which we have, was published several years ago. These data from my previous department, we had nearly 200 patients. Age is very typical, close to 10 years. Follow-up was more than 5 years. What is important is that we concentrated on 2 techniques, simple and cusp replacement. We did the extensions, but I will show you why we abandoned this technique. Survivor is perfect. This is really a safe method, and what is important is that we had preserved LV function nearly in all patients. There was just one or 2 patients where the function was not perfect. Event-free survivor is roughly about 60 to 70% at 8 years of follow-up, which of course it's not perfect if you compare that again with Ozaki, but that's what you can achieve in a pediatric population. And this is the most important slide. We look on like an ideal group. Ideal group are patients where the aortic root is big and the growth is not anticipated, somewhere between 10 years plus. So we had 100 patients of this kind. And you see the different techniques, but the bottom line is that when we use a simple technique, which is green, and leaflet replacement, which is blue, we had an 80% freedom from aortic valve replacement at 5 years, which is significantly better in comparison with free edge extension. And really, we abandoned this technique for this reason. These are the paper which published many data about tricuspidization and so on. But the bottom line is that survivor is perfect. However, freedom from AVR is roughly about 50, somewhere between 40 to 60%. But the most important argument why I'm still doing that is the stabilization of left ventricle function is achieved, and geometry usually is not changed. So you are really not burning any bridges. So these are the take-home messages. Early valve function after reconstruction is excellent. With time, the attrition rate of used material and outgrowth of patches are obvious. Fresh autologous pericardium might be more durable. The best results have been achieved in primary repair and with tricuspidization of the aortic valve. However, the Achilles heel of repair is mismatch between the techniques and material. We need better techniques and definitely better materials. So this is a main conclusion and the whole philosophy behind that. With this time frame, aortic valve repair is considered to be a good temporary solution as it offers reduction of AR and AS and stabilization of the ventricle dimension until the patient grows older, when, if unavoidable, an adult size of prosthesis reinforced ROS can be implemented. Thank you very much for your attention.
Thank you very much, Victor. It's a great lecture, and I'm sure that everybody enjoyed. We're going to start with some questions from the audience. So Tomas is going to start with some.
Yes, we have a question from the audience, and we are inviting everyone in the audience to send us the questions through the chat. And they are asking, how do you see the future of the aortic valve replacement regarding techniques or innovation devices? What do you think will come in the next few years, and what we expect to have in the next couple of years?
So the question is about the future of repair and aortic valve replacement. That's what you asked, Thomas? Yeah.
Yes.
You know, it's maybe the fact that I'm getting older, I'm more skeptical. I experience different type of materials, and unfortunately, all these materials are failing. Whatever you use for this valve is failing. So saying that, it sounds pessimistic, but on the other hand, the adults started the TAVI business, and they are putting enormous effort and money to develop the better materials and, of course, better TAVI valves. So I'm optimistic in that regards that we will have a better material in the future, which gives us possibility to reconstruct the valve much easier. On the other hand, probably TAVI business will invade our specialty as well, particularly in youngsters and older patients. Because if you look on other data, on other results, we can provide the freedom from AVR for 5 years, let's say, and then to make some kind of definitive solution. I think these valves placed with the TAVI technique will provide the same results. So basically, there will be no argument in the future why not to put the valve in the youngsters and older patient, even for other population of the patient. So I see that the TAVI will take over many aortic valve replacement and take over many aortic valve reconstructions. I'm not talking about the neonates or infants or small babies. No, we will have to do it, but you know, in patient about 10 years, when the annulus is, I don't know, 20, 22, they can place nice valve very quickly, and the results are improving every year. Of course, they are facing problems with block and all this stuff, embolization, but I think it's just a matter of time.
Okay, we have another question from one of our colleagues here in Bogotá, Dr. Correa. He's asking about the preoperative morphologic echo characterization of the aortic valve in neonatal aortic stenosis. Is it worth it? What do you need to be, or what do you need from the echocardiographies to tell you about the valve?
Yeah, this is a very good question, I think, because our results and decision making, of course, completely depends on preoperative evaluation. And echo is offering enormous amount of reasonable data. So now, even in neonates, we are able to recognize whether the commissural posts are developed or not, and to which extent the leaflets are fused. On the top of that, one can measure the effective height, and to give you some kind of roadmap, what the effective height of not disease or reference cusp should be for remaining cusp, which helps you in during reconstruction, because you can measure that and you can prepare for that. And on the top of that, we are getting a nice images from the 3D. So altogether, it's about the morphology still. What kind of valve you see, how they are able to demonstrate the area of fusion and mobility and so on. On the other hand, they are offering a very useful matrix to proceed with reconstructions. So yeah, the collaboration between the surgeon and echocardiographer is crucial.
When you use autologous pericardium, do you use any fixation technique? Do you use formaldehyde or fresh pericardium?
Yes, after many years, I returned back to autologous pericardium because I realized that that's the best what Mother Nature prepared for us. We decreased the length of preparation of this patch in glutaraldehyde. We started, I don't know, 10, 15 years ago with about 15 minutes of soaking the patch in glutaraldehyde. Now we soak it just for 5 minutes to have a nice flexibility of the patch. And whether it's going to make a difference, I don't know, but people believe that. Well, we are believers.
Okay. What is your take on Ross procedure for teenagers and young adults, and what do you think about mechanical AVR?
Yeah. So I was big Ross guy. I love this operation actually. However, when you look to the really long-term outcomes, this is a great operation for the first 15 years of life. Of course, there's no choice if you indicate the Ross in small patients. There's no other alternative, so you have to do it. However, the question is whether you should do a Ross in teenagers, and or whether you should just replace the valve. It very much depends on the preference of parents. We have always, or preference of patient, we have always a very extensive discussion about this. Ross definitely offers a lot of advantages, and we know that. However, in this 15, 16 years, the risk of failure, it's not trivial. And plus, there is this problem with the pulmonary valve, of course. So we changed our strategy for the Ross, and now we are doing a supported Ross. Supported Ross in that way that the autograft is placed to the conduit, to the cylinder, and that cylinder supports the diameter of autograft. We have a pretty extensive experience with this, and so far the results are excellent. Of course, it's not dilatation, and the function is very well preserved. I had to reoperate only one, and probably it was endocarditis, something like this. The valve was simply destroyed. It will be not 100% sure, 100% working for many years, that's for sure, but it will improve our result with Ross, I think, in the long term. On the other hand, now we started to use an onyx valve. If patient wants to have a mechanical valve, and there are many of them, many of patients say, no, I want the mechanical valve, I want to avoid the other reoperation and so on. So we are offering the onyx valve because of advantages in hemodynamic and ENR requirements. And plus this self-monitoring technique of anticoagulation, I think can make a big difference because it's very comfortable. Patient doesn't have to travel to hospital or somewhere, can check himself or herself. And there are many data, particularly from Holland and from the other countries, showing that if you use this self-check, you can decrease the risk of embolization and the risk of overdosing or underdosing. So I think both techniques, Ross or both alternatives, Ross and valve, in my mind, are equal, despite the fact that somebody will tell you that, of course, mechanical valve, more embolization. But if you incorporate this other variable, and that's the self-check, you can decrease this risk enormously. So I personally don't have a preference. I leave parents to decide. But in my mind, it's comparable.
Okay, I think we have many questions, but I think we have time only for 2 more questions. One would be, do you ever do any type of procedure on the aortic aneurysm to stabilize it in young patients or young adults?
Yes, we do. I was talking about the Ross, which is placed to the cylinder, which of course the cylinder is stabilizing everything. However, we are doing a Rosses not only in this way, we are doing a Rosses in the way how Indianapolis proposed that the annulus and the ST junction is stabilized. We use this technique in patients who came with aortic stenosis without significant dilatation of the annulus, because these patients, in my mind, needs just these two stabilization for the long-term good outcome for the Ross procedure. One can stabilize the annulus in the repair as well if you consider that as a large. So one has to measure that and accordingly to adjust the annulus with the external strip.
Okay, and I think for the last questions would be, do you change your technique if you have to repair a truncal valve?
If you have to repair what?
A truncal valve, a patient with... Yes.
Yeah, truncal valve is a big problem. Truncal valve is a big problem. I try several different type of reconstructions, replacement of the cusp and so on, but truncal valve is very flat. The coronaries are very embedded to the sinuses, so they are very low. So when you enlarge the sinus too much, you can affect the coronary flow. It's a challenge. I tried that. We achieve good temporary result, but in the long term, usually this patient needs a replacement. If you have to replace the valve from get-go, replace the cusp from get-go. If you can handle the situation with a native cusp, for example, create a tricuspid scenario from quadricuspid, or to resect one of the sinuses, sinus valsalva, and downsize the annulus and improve the coaptation, or just you support the commissure. These techniques works better, but replacement of the cusp, it's problematic, and usually it's a problem.
Okay, I think one short question: do you know, or you think it will be in the next couple of years, any randomized control trial between the techniques and between the repair and the tower?
This is a good question. Of course, there will be tendency to do it, but I doubt that it will be prospective randomized. It will be like a single central experience, and you know, the study business is so strong in this point that it will prevail. In adults, definitely. In our business, it's a different topic, but in adults, definitely.
Okay, I think we have been here a little bit longer than an hour, and we want to thank you very much for this very interesting talk. It was an honor for us to have you here.
Thank you, Victor, again for being with us. I think it was a great presentation, like usual. We are very proud to have you here in our institution, and everybody was very happy to listen to you. So hopefully we will have you again in the next couple of months with another very interesting topic that you are an expert. So thank you, Victor, for accepting this invitation, and you're always welcome to this Fundación Cardioinfantil.
Thank you very much for the invitation. It was really a great honor and privilege. Thank you very much. Have a nice day.
Have a nice day. Bye.
Bye-bye.